Just a little bit about Akron Children's Hospital. We're in Northeast Ohio, and we're the 8th largest children's hospital in the country, but that is a freestanding children's hospital. And just wanted to show a picture over there of our Air Bear, our famous helicopter that we're well known for. So you could push forward one. So a little bit about the Lewis H. Walker Cystic Fibrosis Center. We were established in 1950 by Dr. Lewis H. Walker. We're accredited as a clinical, teaching, and research CF center. We care for more than 240 patients right now. We have about 140 pediatric patients and about 100 adults. And we use the team approach from the CF Foundation, multidisciplinary. We have about 7 doctors and 2 nurse practitioners and about 40 support staff. That really is for pulmonary in general also.
And not to interrupt, so that's a similar size to our center. We have about 100 pediatric and almost 100 adults.
So some unique things to Ohio. We are actually have one of the largest populations of CF patients in the country. We are around between like 5 and 6. So a very large CF population in Ohio. So we have 6 CF centers. So in that way, it's kind of nice. We're actually a little more geographically close than maybe other CF centers. So typical distance to our center is about 2.5 hours. But I would say most of the time, most of my patients are within an hour or so from our center. We're 1-hour drives to Holmes County, which is our Amish country. So by car, it's an hour. By horse and buggy, you're looking at a full day. So, but we do. And I love my Amish patients, but they pose different challenges. So about 10% of our population is Amish. So our pediatric team has a CF-focused clinic every Wednesday morning and afternoon. And we also have an adolescent clinic, and that adolescent clinic meets twice a month, and we have it later in the day for our adolescent patients who don't want to miss school or activities, those things. They have the full team approach in the adolescent clinic just like in the regular clinic. We also implemented something new this year. We have an exacerbation clinic where we see patients twice a month just for acute visits, and that's really nurse practitioner-run clinic. And it's really doesn't have every team member there. It's really supposed to be more focused care. What's something that's a little different from our pediatric side versus our adult side is most of our patients are assigned to one physician, and they follow that physician most of the time. Sometimes they may see someone if they're sick, or they may see the nurse practitioner if they're sick. They may see them when they're hospitalized, but for the most part, they follow one physician. Okay, move to the next. Our adult program is also has adult-focused clinics. We have them every Monday, 3 Mondays out of the month in the afternoon. We have 2 doctors and myself, the nurse practitioner. And I'm also available during the week to see patients. So I spend some of my time coordinating the program, but I do a lot of nurse practitioner work. So what's unique to Akron is we still have an older model of the pediatric hospital, and we admit our adult patients still to the pediatric hospital. We have a separate wing where our patients are at. And it was made specifically for adult patients at Children's. We do have some cardiac patients that might be admitted there at times too. And what's a little different how we practice is we share the patients equally. So at any given time, the patients realize that they may see myself, Dr. Shears, Dr. McBennett, and they're pretty much used to us, and we practice very similar, and we follow each other a lot. So it's a little bit different in practice. Okay?
Well, I don't understand, Christine. So they're assigned to one doctor, but you share them among the adult doctors if they get admitted.
So for the adult center, we're actually, so this is a little different from the adult versus the peds. The adult side, we all share them equally. So at any time we have clinic, we have appointments, and then we kind of go in and see patients as we need to. So there's nobody who's really their doctor.
For adults.
Yeah, for adults. So just a breakdown of our team members. We have nurse coordinators, our dietitian and our social worker are separate, peds and adults. And then our physical therapist, our respiratory therapist, genetic counselors, our research nurse and our registry coordinator they're actually cover both adult and peds. So there's a little bit of overlap, and that's been fairly recent because we've actually added a few members recently. We try to meet often, and we've been trying to increase this recently. Meetings every Wednesday morning of the last Wednesday of the month. We have a yearly retreat where we get together and we really kind of go over things and look to see what we need to improve, discuss issues that have come up, maybe do a little bit of education too. And as I was saying, a lot of new CF team members recently, so we're really growing. We do something called a case review, and we do this bi-monthly for our PEDS patients. Every patient gets a case review once a year. So it's an in-depth conference with the whole team. And we do the same with the adult patients. Case conference is prior to all adult clinics. So we take maybe 2 to 4 patients and do an in-depth conference. And then we have a biannual transition case review. And that is right before we transition patients over. So we can move on to the next slide to talk a little bit of how we transition. So we try to take a planned and coordinated approach. We look at our patients around the age of 19 to 20. That's when we decide to transition after they've gone a year into the world, after graduation, start a new job, college. That way they're not dealing with too many changes at once. And then we get together for a meeting, and we usually do anywhere from 3 to 6 and twice a year. So this last year we took close to 15 patients from the PEDS team, so we're really growing on the adult side. And then we have the in-depth case conference with the whole team present, and ideally, if we can, the adult team tries to meet the PEDS patient before they come over, so that way they have a familiar face. I don't know why that got put in front there. Sorry. Let me go back. So anyways, let's move into our outcomes. So what I wanted to talk first about a little bit is our therapies. So what do we do at Akron's that kind of makes us unique, and how do we practice? So right here, looking at pulmazine and hypertonic saline. If you look over on this side of the graph, these are the registry graphs that we get back that are. I could use the. Yeah, there we go. So these are patients. So this is pulmazine here. And these are patients, these are individual CF centers here going down. So you're looking at over 160 or 70 different CF centers. We're the red line here. These are 100%. So CF centers over here that are using pulmazine 100% of the time. We're kind of a little on the lower side here, but not too far from average. So we typically use pulmazine about 76% of the time in our patients. Hypertonic saline use, not big adapters. We're still down here around 27%. And I would say for our adult population, we're even lower than that. We really don't use it a lot. Just with our problems with asthma and hyperreactive airway, the patients just have a really difficult time tolerating it. So have not jumped on the hypercell bandwagon yet, although I do think it's good depending on the patient if they tolerate it.
So I want to make sure I understand that. So the why is because your population struggles with it more than others? Or
I think it's something that we've seen, and I think it's probably practice differences, just what our physicians have seen, and they have not been comfortable because we've seen people drop so much and have difficulty tolerating it. So I think it's just the individual patients. So, and how they.
Practice pattern.
It's a practice pattern for whatever reason.
That's why these practice patterns are so interesting. They happen
and we don't even realize it.
It's
Yeah.
cottage industry, we know.
And I think you have a case of a couple of patients who didn't do well on hypertonic saline, and from then on you're like, well, I don't know if I want to put somebody on hypertonic saline. And
what about Dornase? Because there hasn't been that many reaction problems.
yeah, again, I don't know why this is. This is an area of improvement, and it's actually very well tolerated. So this is what we get from this data now. This data just tells you one piece of it. It doesn't always tell you, like, maybe we've taken the patient off because they're not doing it, or there's maybe some adherence issues, maybe there's insurance issues. So certainly it's a piece of the data, but it's not the whole story. So it may be a little more if and maybe we're not collecting the data well either. Maybe we're not getting it every time.
Does your Amish population have limitations on what you can do?
Usually we try to work around them. So we try to.
Does that affect your data?
It can. We think it does. It's 10%, and we think it might. But it's. We tried to pull out the Amish patients to see It doesn't make a huge difference. It really doesn't.
Do they have health insurance?
We have something called BCMH, which is Crippled Children's, which covers most drugs and those. It has its limitations also, but it can get to some. My bigger issues are electricity and transportation, typically. So, yeah, exactly. So, I don't worry so much about the. I usually can get them met. So, but we can move on to the next one. So, beta agonists like albuterol. We tend to use quite a bit, 95%. So I don't know why this got behind it. I thought I had corrected this.
That other one back?
Yeah, we'll go back to the vest. Sorry. There we go. So this is just our airway clearance patterns and what we use. We are big proponents of the vest. 68% of our peds patients and about 70% of our adults. PEP, flutter, acapella, IPV. 7% for peds, 16% for adults. We do use, I think, this a lot as a secondary form of airway clearance. And then postural drainage, the pediatric program is much higher with that, about 15%. And our adults, very few. We could go through this, thank you. And then, so this is how I'm trying to break this down into certain groups of treatment. So we went over the airway clearance group. Let's move on into anti-inflammatory meds. So I'm going to talk a little bit about ibuprofen here. So we could move to the next one. So we have a pretty high use of ibuprofen at our center, right here. And as you can see, there's not very many centers, so it's not really widely used right now. So we can move on to the next slide. So we're 5th in the country for ibuprofen use. So you could first start with this piece. So what do we know about ibuprofen? I thought to talk a little bit about it because it's a little unusual. We do know that there can be a decreased rate of decline in FEV1 by 4% a year, reduced chest x-ray progression, increased weight for height, and reduced need for hospitalization. So this work was done by Dr. Mike Constant, who is at Rainbows Babies and Children's, which is only 40 minutes from our center. So if you want to move forward a little bit. So this is a projection of someone who not on ibuprofen over a 30-year period. So when you look at a 4% year decline, if you want to press again, this would be the difference. I'm sorry, 4%. So you see that it can make that much of a difference by 30 years. So it's surprising that it's not used more often, but there are some concerns with it. Move to the next. Well, one thing you need to start in patients who are young and with an FEV1 greater than 60%. One nice thing about it is it's easy to take. It's a plus. They can take a pill usually twice a day, but it's very high dose. I have some adults that are on 1,800 milligrams twice a day, so very high dose medication. You need to have pharmacokinetics to make sure that you're getting to verify correct dosing as the child grows and their weight increases. And that can be a little of a inconvenience, but it's not too bad. It's usually about every 2 years. The patient has to fast, and they have to fast for most of the day because they usually take the medication and then they get blood work drawn at intervals over a few hour period. So sometimes it's a bit of an inconvenience, but when you're looking at once every 2 years, it's really usually pretty doable. So some concerns we have: it can cause gastrointestinal upset. There can be some blood thinning properties to ibuprofen. So anytime we get concerned about gastrointestinal bleeds and other bleeding like hemoptysis or bloody noses or coughing blood. So especially on our adult side, we have patients who are on ibuprofen. We don't usually start them because we typically don't have that type of patient. Yes?
Once they are on it, are they on it continually, your adult?
As long as they're not having problems, we keep them on in our adult program. We do. And unless they start having bleeding, we don't typically stop it. But the minute they start having any bleeding, like even I've had some patients, some males with some blood in their urine, those patients we've stopped, and bloody nose. We haven't really had GI bleeds. It's been other bleeds, coughing up blood. Yes?
When you say young patients, you must have
Greater than 6 years.
Greater than 6.
Yeah.
And have you started, someone been on ibuprofen for a long period and they have to go off?
Yes.
Have you noticed a decline?
I would not say that we've noticed, no. I think that usually the momentum pretty much stays. And what the literature shows is that FEV1 continues to decline at that trajectory. So it's not some drugs like Pulmozyme where you put someone on Pulmozyme and they have that immediate increase of 10% in their pulmonary function. With ibuprofen, you see that maintain. So typically, it's not a problem if you take them off. And there can be effects on the kidneys as well. And when you're looking at our patients and the IV drugs that they're on, also possibly looking at lung transplant, which can affect kidneys too, some of the medications that we do have those concerns also. But if you can keep someone well for years, then it's kind of a risk benefit. Yes?
Question. If you have somebody who's chronically getting headaches a lot and they're on chronic ibuprofen at high doses, do they eventually get kind of immune to the ibuprofen for pain relieving purposes?
And I can't say that I've seen that been an issue. No. Yes.
On the issue of trajectory of slowing the decline in FEV seems to continue. Are there studies being done that might help with where to cut off the ibuprofen use because you've already reached a tipping point where it's done its maximum effect?
I'm not aware of any studies right now on ibuprofen, so no, there really isn't any. And she was asking about if there's any studies on the decline in after you stop ibuprofen and when to stop. But there are no studies at this time. Yes?
Do you want to talk about possible problems if you're non-compliant? Making
Yes.
things worse?
Yes. Yeah. Yes. She would like to, as far as being non-compliant with ibuprofen, would you want to talk about that in particular or any of the it really...
Just the risk that was raised about you could possibly have an adverse effect with
Yes.
non-compliance.
Yes. So the question is, could there be an adverse effect with non-compliance? So as I was speaking of earlier, a lot of therapies, when you stop taking them, you can see an effect in your pulmonary function, and we're really talking about more pulmonary meds today. So, in something like ibuprofen, with the pharmacokinetics and how they need to be maintained over time to stop that type of therapy, you may see not necessarily a decline, but at the same time, if then you restart, you may have some problems, like the GI bleeding or those things. As far as not doing all your therapy, or as far as adherence goes, with other therapies, with Pulmozyme, if you stop, we do know that there can be a decrease in your FEV1 by about 10%. So you function better at a higher FEV1, and you're able to produce more sputum. So again, compliance is very important. Okay? I don't know if I was totally getting at what you were asking there, but inhaled and oral antibiotics. So I'm going to talk a little bit about tobramycin, aztreonam, and colimycin. And then I put Zithromax here under antibiotics, where it actually we think to have some anti-inflammatory effects. So it could maybe be up here, but I thought just to keep it simple, let's deal with it as an antibiotic so we can move forward. So inhaled tobramycin, or Toby, as you can see here, again, we're pretty average. We're not, and I think this number over the last couple years has come down maybe just a touch, but 65% about average with most centers. And really, when you're looking at this data and how it's reported from the CF Foundation, there really is no top 10 center when it comes to this, because the thought is that you use these therapies when you need to, when people are eligible, but there are people who can't take these medications, whether they don't tolerate them or there may be other issues that they may have. Inhaled aztreonam, not big adapters either. This was fairly new this is 2011 data, so we're looking at 2 years ago, and I think this number is starting to come up. But again, there's some people over here that are really using it a lot more often.
Christine, what is aztreonam?
That's Caistin, I'm sorry.
Okay.
Mm-hmm. And then inhaled colistin. Now this is a not approved, FDA approved inhaled antibiotic. Does anybody, I don't know if your center still uses colistin, but as you can see, we actually use it as much as this one. So, and it's not even approved. So, so we're still using this. So again, a practice pattern that once patients are on it and they're doing well, sometimes you have a hard time taking them off of it. And a lot of times what we would used to do is use Toby in conjunction with colistin if a patient wasn't doing well. And now we're starting to do that with Caistin. And the patients with, I think our center has a lot of the, our goal is to keep the therapy burden down as much as possible. So we haven't been so quick to just put everybody on something. If they're doing well, we may not jump on the bandwagon right away. Zithromax, though, we love. I mean, that's pretty good. It's not all the way up here, but it's higher than the national average. Well tolerated, easy to take. The monitoring is, pretty easy. So, I think we've been big adapters of this. So, frequent monitoring of health status. So this is part of CF care. Quarterly visits, PFTs, and cultures. So moving forward, and I think this is one area we do pretty well. So patients 6 to 17 years of age with 4 cultures, 4 visits, and 2 PFTs. This is for our peds patient. And if this is for our adults, 4 cultures, 4 visits, and 2 PFTs. So if you just click forward, this is one area we've really tried to improve on. And then click again. And then click again. And as you can see here, not as fancy as Dr. Sears' animations, but I'm trying a little bit.
Show off.
So we've made an effort to do this, to do better at this. And we could go forward. I'll show you what we've done. So one thing that we have, and I think you also have this here, is EPIC, the electronic medical record. And this is our EMR. This is the first page when you pull up a patient. So there's an area, it's called the snapshot. And one thing that's really hard in CF is keeping all of this information of these very complex patients in order and straight. And if you don't have a system in place, it can be, when patients come in, it's difficult to know what do we need to do today. So this area that we've developed in our snapshot looks at cultures and their exacerbations. So what we've been doing now during pre-clinic, before patients come in, is that we make sure that all their cultures are up to date and they're compiled. So we can look back in an instant and see, this is what they've grown, this is what we've seen recently. And then we do the same with exacerbations here. We constantly compile every time they're being treated. So again, we can look back and see, okay, this is what they did recently, this is what worked, what didn't. We also have the huddle prior to clinic. It's a quick time. This is our nurse coordinator, Peggy, here. And as you see here, she has the board behind her. This is like a snapshot also of what's going on. We do this a few minutes ahead of time before clinic, make sure everybody knows who they need to see that day, what they need to have done. Do they need cultures? Do they need lab work? Do they need their port accessed? So it's a kind of quick down and dirty right before clinic, so everybody is kind of on the same page. This is, I was talking earlier about the CF case review. This is something we do yearly on every single patient, except for peds, we do it every other year, but on our adults, we do it every year. It's an extensive chart review. We actually look through we keep compiling it every year. Sit down at a table, we go over every patient very in depth. Every multidisciplinary team member has a chance to bring up something, plans and recommendations. We take that document and we take it to the patient at their annual. So they know, kind of what we think is going on, and we have that discussion then at that time. Okay? So this is where I'm going to be humbled a little bit. This is our pediatric pulmonary outcomes in our CF clinic right now. So not great, although if you see here, we do have a little less variation than you see amongst the adult CF centers. So we're about, right now, medium FEV1, national average is 97 and ours is 91.8. And then this is for 6 to 12-year-olds. And then for our 13 to 17-year-olds, a little lower there too, and we're about 83.7. But if you go forward, so this is where we are now as a whole from 6 to 17 years. Now, if you click, this is where we were about 5 to 6 years ago. And that's where we've moved to. So I'm going to talk a little bit about how we've moved forward. And if we could go to our adult outcomes. Our adult outcomes fare much better. We are at about 73%, we're above average for this. And then we're also at 62% for age 30 or more. And if you can see here, and if you click again, this is where we've moved over the last 5 years also. So we moved up a lot. Now, I would like to say that's because we just really, really rock on these patients that are 30 or more. I think some of it is also we have a higher population of patients now, but I think it also shows that we're given really good care now in our 20-year-olds. So you can move on. And this is just so I think it's important to note we do have a high incidence of diabetes at our center, and I think a lot of it is related to. I think diabetes is a marker for severity. So whether or not this is because we just have more severe patients, or it's that we just find it more, possibly. But we do have, I think, a fairly sick population. So treatment of pulmonary exacerbation. So this is kind of going into our QI work at Akron Children's. Move forward. So in June of 2004, our center became involved in a quality improvement LLC, and we actually looked at our 2002 data, and at that time I had showed you where our, we were pretty low as far as our pulmonary outcomes in our pediatric patients. But one thing we noted is that our adult team treated a lot more for their CF exacerbations, and so we wanted to really increase our pediatric patient population pulmonary function. So we can move. So we decided to design a scoring system to kind of capture all the exacerbations that we saw in clinic. We were going to implement this score on every patient that came into clinic, and we were going to really look at the FEV1 of our patients 6 to 18 years of age. So this is just an example here. What we did is one of our physicians in our center did a case scenarios with all of the physicians or all the providers in the center. He gave us 30 case scenarios and had us say whether or not we would treat with IV antibiotics. So if you could click next, so you can see there is a lot of variability in how we treated. So you have somebody down here who treated 10 times out of 30, and then somebody over here who probably about 23, 24 times out of 30. So a lot of variability and a lot of room to improve.
When you say treated, I think I know what you mean, but can you just maybe?
So you wanted to clarify what treatment means.
Yeah.
So it means treated with IV antibiotics, which is considered a more aggressive therapy, and actually it was specific to IV antibiotics. It wasn't the oral antibiotics. Most of the patients in those case scenarios were already on oral antibiotics. So it was to see how aggressive we were going to be to take the next step. Yes.
Yeah.
So this is our pulmonary exacerbation score, and it's kind of a quick little thing that you do on every patient that comes through. As you can see here, we have cough, we have sputum, shortness of breath, chest exam, and then we look at objective factors like what's their FEV1 today, any new changes on their chest X-ray, any blood recently from their sputum, and then what's their saturations. So if you add them all up, we get a score down here. So we decided as a group, let's be a little more aggressive. Let's say 5 or more for a score. So we decided 5's the cutoff, if you treat or you don't. And then we wanted to watch what happened.
Can I interrupt?
Mm-hmm.
So this kind of score is given when someone comes in unwell?
Yes, for both. Anybody, if they're sick or
Every time they visit?
it's on every visit. Doesn't matter, it could be an annual, we still assess it.
And how did you communicate this change in practice with the family?
We sent out information. We didn't really say what we were doing as much as we told them we were part of a project and we were going to be looking at treatment of pulmonary exacerbations. We've done more as far as education after that, but in the beginning, really it was more of a communication. This is what we're looking at. And we really wanted to see what happened first when we just did the questionnaire or the score. And then after that, we did a little bit more teaching. But now my family knows, they tell me all these things as they go through. Yes?
I think one thing to note and why we looked at this, because when they started this project was a national leadership project, and the changes in practice that they've influenced across the country is pretty impressive.
There's been many centers that have adapted this, and I know there's even some, it's been used internationally in France and Australia, so a lot of people have borrowed it. Yes?
How long have you been using the system?
We have been using it now since 2004. Late 2004? Yes.
I will say one thing about a scoring system, though. I've talked to the doctors at Akron quite a bit about this. It's very helpful when you have multiple physicians. So when you have a big group, 7 or 8 doctors all treating, it's very helpful. It's not quite as helpful when you only have 2 because you tend to be doing similar practice patterns over and over. But what they found, as Christine showed us, their practice patterns were so widely variable that they were bringing them in and making them narrower, and that's part of what made a big difference.
And that was part of, sorry, Dr. Steers, did you want to say that? Okay.
No, I just want to say, we do this on the outside, for every
Yep.
same deal, and we don't.
Yeah.
It does at least force you to prove to yourself why you're not.
Sure.
Their PES is greater than 5, and you're like, I don't want to give them IV antibiotics. You have to, put some thought into that. Why am I not believing this test? And so it tends to bias you towards.
Yes. And it was made to be a little bit on the lower end, more aggressive. It was absolutely.
I think it's also a little biased towards adults.
Yes.
Because, I can go down there
Yeah, it
and we admit people all the time who are less than 5. So
Yes.
they don't have any,
Yeah.
they almost have maybe one
Yeah,
at
because
the
they just have
end.
cough and sputum. If that's
They have
it, then
cough
yeah,
and they have nothing
yeah,
else.
they have
So
nothing else.
it's- yeah.
Or not even sputum. You're right, because
Right,
of peds it is.
exactly.
Oh, that's a
So
good point.
They have no dyspnea, no, so.
Yes. And speaking of the one thing that we had thought, part of looking at our practice patterns at the time was that at the adult center, we actually practice a little more similar. So the thought is if we all kind of come in together, all kind of do the same thing, speak the same language when it comes to treating exacerbations, maybe we can make some improvements. So we looked at this for 2 years. We've been looking at it since. But we first started with 2 years. So every patient that came in, we calculated a PES, and greater than 5, we treated with antibiotics. Treatment of antibiotics was recommended. Nobody had to do it. It was recommended. So we wanted to see what happened if we did. And the physician dictated that. So whether or not it was greater than 5 and they decided to use IVs or they decided to use orals, it was up to the physician. So then we monitored how much we used it. So we used it 91.6% of the time. And how adherent were we? Over that period of time, we were 86.7% adherent. So we most of the time decided to use antibiotics, whether IV or oral. So we looked at then the median FEV1 of patients 6 to 18 years old. And we saw an improvement. And the first improvement in the 8 course. So you could keep going through here. So this is when we started the PES. And keep going. And we kept going. We came up. And we came down a little bit there. And we were real nervous. And then we came up again. And then we kind of settled there.
Was there a flu epidemic about that time? Or?
And you know what's interesting? We do see a para-influenza usually in September, and it seems like we see this dip every couple of years in September for whatever reason. So,
But the population is, you're going to have randomness. You're
Yes,
talking 100
yes,
people, right?
yes.
Yeah, it's going to be
Yeah.
variable.
Yeah.
Just by
Looking
nature.
at that
250
September dip
people.
back in
Yeah,
well, yeah,
that
there's
could be
more.
random.
If you take out those less than 6, and this is actually 6 to 18, it was
Yeah,
probably about that. Okay. And then you keep going. Sorry, this has got a little bit of, yeah. So this was the improvement that we saw. And we've maintained that for the most part. And we've even had a little bit of an uptick here with our 6 to 18-year-old data. So it's been maintained over time. So one way of course, everything changes. And we now have the electronic medical record that I was showing you earlier. So this is how we do it now in our system. We actually have a doc flow sheet where we have set up that we can actually put the PES in, and it calculates it for us, and then we actually pull it into our note. And then it's easier to find. So it's, with change, there was a little bit of a decrease when we first started using it, but we're still above 70% with using the PEZ on a bad month. Typically, we're above 85%.
What's amazing about this to me as I look at this is you're basically managing behavior of physicians.
Mm-hmm.
It's not the meds, it's no science here, it's just
No.
behavior, it's practice
Yes.
patterns we're talking about.
Yes.
And you have fairly small groups,
Mm-hmm.
statistically. Wouldn't it be awesome if 2-person physician groups and 7-person physician groups could just meld all this data together and kind of compare to get, to just at least bring the lowest up to the average?
Mm-hmm.
That's a
Mm-hmm.
massive improvement. But you don't have to be sterling. You just have to
Yes.
be average if you're below
Yeah.
average.
Yeah.
It's just amazing to me how just a subtle thing like this.
It's very simple.
material.
It's very simple
Change.
change.
QI things.
Mm-hmm.
Yeah, yeah.
A very simple
Do
change.
you, not to jump ahead, Christine, do you graph out how many, your change in number of patients admitted to the hospital, number of patients treated, number?
We do. We have a dashboard, and I actually was thinking, I wish I would have put a picture of that up there, but we do. We call it a dashboard, and it just shows you where you're at on a quarterly basis with different pieces of information. So one could be just our quarterly exacerbation rate, how many patients we use orals for, and how many we use IVs for. We also look at our follow-up from oral antibiotics and IV antibiotics, how far out we see them. So those are different pieces of information that we're continuing to track.
But that must have all gone up. I mean, you must have admitted
Yes.
so many more people.
And you can see that, yeah,
so many more.
yeah. I'll show you the little bit of. So clearly we are crazy about this because we're continuing to look at it. And so in 2008 and 2011, we applied for a quality improvement grant from the foundation, looking to actually use the PEZ, not only just to define an exacerbation, but how severe was the exacerbation? Did the score improve with treatment? Was the score low enough when is the score low enough to stop treatment? And how are we monitoring our hospitalized patients? So how often are we seeing them and are doing our PFTs, those things? So, yes.
So your goal was to sort of use it, when your score drops a certain amount, then you can say, yep, we're done.
Yes,
Send
yes,
you home.
yeah, exactly. So if you move forward a little bit, so this is an algorithm we came up with that, and it's really small on this screen here, but this is so this is a PEZ greater than 5, so you have to assess the severity of treatment. Sorry, I have to look a little bit more here. It's kind of blurry. And then these are PEZs. This is 3 to 9. This is 10 to 12. And this is greater than 13. So these are kind of the recommended therapy through. So we recommended at this point a 5 to 9 oral antibiotics, 10 to 12 IVs, and then greater than 13 hospitalization. So we took something that was a little less complicated, a little pretty simple, a little more complicated, and kind of defining what was a mild exacerbation and what is a severe exacerbation. So along that continuum. And then using the PEZ to then reassess every time you see that patient to see, are they having a change in score? Is their score getting better? So.
You have to realize when you go to the CF national meeting, they have hour-long lectures just trying to define what a pulmonary exacerbation is. No one can agree. It's so complicated, and so it sounds like it should be so simple, but it's actually not.
It's not. It's not simple at all. This is our hospital treatment algorithm. So this is something we became a little more aggressive with this project, looking at PFTs when they're admitted and looking at their PEZ score when they're admitted. So starting on day 1, we do their pulmonary exacerbation score, and we do a PFT. And then starting from day 6 on out, we then look at their PFT data and their PEZ data to see if it improves. So we actually, what's interesting, even with doing the, as you can see here for Children's Hospital, we're pretty aggressive when it comes to using IV antibiotics. So these are patients under 18 years of age. We're about, national average is 26.8, and we are 37.9. For adults, national average is 44, and we are 56%. So we like to use IV antibiotics, yes.
So you're going to talk about length of stay? Or no?
Yes, that'll be my next slide, I think.
How long have you been doing the PEZ for? 5 years or something?
At this point, this is 2011, we've been doing it about 6 years. So this has gone up, but it actually went up much more soon after we initiated the PEZ score. Really, this data has stayed fairly stable over the last 4 to 5 years.
So it didn't go up.
No, not, initially it did. I'm sorry, with our peds patients, it went up. With our adult patients, it did not. Our adult side has always been very aggressive with IV antibiotics, so we have stayed around this average. Yes.
Do you routinely admit pediatric patients on a, say, yearly or every few years?
No, we don't. We don't. I would say there might be a few exceptions of that, where we do, we have, maybe somebody is going to go somewhere over the summer, and we might bring them in to get them tuned up before they go on vacation or something like that. But typically, we base on symptoms.
Are you aware of any centers that do that?
No. I think it used to be a practice that happened a lot more. They would call them tune-ups and those things. And I've had some of my older adult patients would do that, would come in and do just kind of plan when they would be treated. But usually by that point, they were already starting to have symptoms. They were already starting to. So it was really still a regular exacerbation. It was time for them to come in. But we usually base it on PFT. At least having the PFT and some symptoms with it. That tends to be the majority of what we see.
So in Scandinavia, they do that. Some centers in Europe do it. They admit regardless of symptoms. They just admit.
And what is their outcome? Is it higher?
It's very good.
They're good.
But it's very good for many reasons. Yeah.
Is that balanced with whether they proactively did comprehensive treatments in the hospital or proactively did comprehensive treatments but out of the hospital? Because we're showing data here, right, that indicates that we should be putting people in the hospital until really necessary because there's so many other risks of doing that.
Well, that's controversial, though. To say that people are worse, you mean, if they're in the hospital?
Well, trying to avoid hospitalization. It's a big issue we're dealing with
Infection.
Because of infection control, you mean?
Yeah.
Yeah.
I'm just wondering,
Yeah.
like the Scandinavian stuff, that would probably have to be drilled down further to show whether it's the treatment itself or the setting, whether it has to do with admissions or has to do with just focusing on a patient.
There's a lot of factors.
Yeah.
Even payment systems in the United States, we
Yes.
require medical need, whereas in
Right.
Europe, it's nationalized health care. So there's a different attitude about things like that. So.
Okay, you're good. Oh, I'm sorry, that was length. I apologize, I thought you didn't. So length of therapy, so this is pulmonary exacerbation. So we treat a lot, yes. And then we treat longer. So our peds patients, we're treating 15 days on average. This is hospital or a home. This is IV antibiotics. Our adults, we treat a lot longer, about 18 days, versus a national average of 14 days. So these are percent of total treatment duration in hospital. So the percent that actually stayed in the hospital for the whole exacerbation. So we tend to be a little on the lower end for this. We tend to do a lot of home IV. Or we bring them in and then we send them home. Okay?
And it doesn't tease out how long you bring them in for.
No, but yes,
days a week.
it could be. Yeah, we don't have that. I may have that data if I could probably pull that data out somewhere, but we don't. Yeah.
Sorry.
The question is, it doesn't tease out how long we bring them in for, and so, and actually, if I look at the next one, it might give us. So medium. Here's hospital length of stay. So this includes patients that were here for just a day, 2 days to start, and then can go as long as a few weeks. So peds side, we're about 8.4, which is still a little lower than the national average, 9.5. For the adults, it looks like we're around 11, which is a little more than the national average of 10. So why we do hospitalization at our center is really for close monitoring of response of treatment, especially in those patients that are very, very ill. And we need to see if they're going to get better before waiting another week for them to come back to CF clinic. Patients are able to concentrate on their care a little bit more instead of worrying about other responsibilities. We do monitor their PFT much more frequently now, and then we monitor their exacerbation scores throughout the hospitalization. And the EMR has made this much more challenging with implementing EPIC over the last year. So still trying to improve on this.
What's EMR? Sorry.
Electronic medical record, sorry. EPIC, which I think you might maybe know that.
How has that made that more difficult?
An EMR will change every process that you've ever done. We'll change it in the center because everything changes, whether it's now you're dealing with a screen instead of a paper chart, and before we had it just on the piece of paper. So we would do the PES scores, we put it on the chart, it was right in front of you, you did it, and then you handed it in to the charge nurse before you left. Now it's in a separate part of the electronic medical record, so it's more of a memory. You have to remember to do it. We don't have that type of reminders in the system yet, and if we do, we have to kind of find those or optimize those in our.
You need an iPad. Sorry.
Well, is that what
We need
Doesn't
to.
work on the iPad.
You need it to work.
EMR
on
doesn't
iPad.
work on the iPad.
Fix it.
So,
They gotta fix it.
iPad's just a big phone.
I wish
Doesn't work
Steve
on the
Jobs
iPad.
would have created an EMR.
Should
So
be
yes.
so having a screen in the examining room, isn't that serving that purpose? You can just input data as you're going. Is that what we're talking about?
Well, the part of the problem with, I totally agree with Christine, is that before, if you want to track something in a piece of paper, you just make a piece of paper and you graph it and you put points on a graph. But in the hospital, say for instance, like if we want to track PFTs on a graph in the hospital, we have to go through, red tape beyond red tape to find the right person to create the right graph, to link it to the right, which often just is impossible. So we just can't do it, whereas before all we had to do was make our own graph, put it in our pocket, put it in the chart. It makes some things wonderful, but it makes other things a little harder. Yeah.
And I wasn't. Oh, go ahead. I'm sorry.
I was gonna say, in a more practical way for the families is that for your prescriptions when they come over, it's completely different. Now they can't just write what they want. They have to pick from a menu, and it may not be exactly what they want or how they want it to say, and so the scripts come over kind of weird, and then we have to call, and then it delays everything, and it's just another example.
Yes, it is. It's very complicated. The screens are very detailed, and there's a lot of information on every screen that you pull up. So, and then again, the time that it takes to optimize. So, we're just one place in a big hospital, and everybody has their needs. So you get put on a waiting list for these types of things. So, okay. So then for home therapy, so the way we do home therapy now is patients are seen weekly. We do an exacerbation score at that time and a PFT. And we need to have telephone accessibility, although with some of my Amish patients, it may be their local driver who will go and tell them, they need to speak with you, or, we work our way around it. So weekly labs and IV care. And what's nice about it is patients are able to go about their normal day as well as they can while they're being treated. So right now we're working on resolution of pulmonary exacerbations. And what do we do when a score never goes below 2? So we have a group of patients that we have seen that just don't go below that score of 2. And 2 is like our cutoff. You're done with IVs. You're okay. Then you can finish therapy. So right now, looking back at our charts, what we've really found is that most of the patients feel better at that point, but their FEV1 has not gotten back to baseline. So looking through how far do we extend therapy, when do we stop, when do we cut off? Typically for our center, the cutoff is around 4 weeks. We don't usually do any more than that. There's been a rare patient that we've used 5 weeks for. So one thing I always like to talk about too in CF centers is phone treatment. How many exacerbations are you missing by treating over the phone? So we got together and we also decided to standardize our treating over the phone in our center, making sure that we're all kind of doing the same things so patients expect the same things too. So we established a phone exacerbation protocol. And another thing that we had seen when we did do this, and we could move to the next slide, is that this was not a great thing for our center as far as our patients. I mean, it's pretty good. People thought we were pretty good as far as phone access, but we had a lot of goods and fares, and we had a lot of comments that it's really confusing calling into your center. Who do you talk to? People are part-time. So we thought this is an area that we can improve. So we decided to flow chart it, and if you move to the next slide, we saw that this was a mess. So it was all over the place, and thought, okay, this is an area to improve therapy. So we came up with a telephone triage form, and we also developed a telephone tree too that has now been in place for over 7 years. So that there's a quick, easy access where the patient calls in, and if they're sick, they press 0 and they get to speak with somebody immediately. The phone call, it's now very simple because this is some areas the electronic medical record makes it easier, especially when it comes to phone calls. I can get that information within minutes after they call. Before you had to pull a chart and all that. So bigger things that we wanted to look at, making sure, what was there any major signs and symptoms that have changed to bring the patients in, like hemoptysis, chest pain, shortness of breath. And then we also modified our PES score and to see if we could treat over the phone. The bigger thing that we were looking at is we wanted to make sure that we were bringing patients in and that we weren't over-treating on the phone. So they would call and we'd treat them and they'd call back a month later and we'd treat again. We wanted to make sure we weren't we weren't missing a severe exacerbation. So that helped. Another area that we are looking at right now with our teaching and with our patients is our CF action plan. And this is actually more at home for them to do before they get to the center, before they get sick. So smiley face green and yellow for kind of not very smiley, and sad. So major issues, things are going great here. You're doing well, you're doing your therapies, everything's fine. Yellow is caution, not feeling well, coughing more sputum production, maybe a fever. So what to do at that point? Increasing your albuterol, doing more airway clearance, waiting 48 hours, if not better, calling us. And then really bad things, chest pain, bleeding, really bad shortness of breath, you need to call right away or call 911. So just an education tool at home before they call in, where are they at, and what can they do ahead of time?
I have a question. Would people find that helpful?
Yes.
These are tailored to the patient.
They are tailored to the patient. So not everybody's on these medicines. These are just but certainly it is tailored, and our EMR, it will make it so that we have drop downs for that.
So is this something that they can print off?
Yes.
They have to take a stack home?
Yes. This will be a to-go, and this will be done every time they come in.
I have a quick question.
Yes.
Maybe you're going to address this as well. And how is the primary care physician run into the loop with this? Some people who are an hour away and just feeling kind of not well, and they go to their primary care physician. Are they on board with some of this stuff? And how do you talk to them? Well, we
tend to usually try to pull our patients in from a pulmonary standpoint. Whenever they're sick, to call us. We do sometimes we'll shoot it back to the primary care if we feel that it's more of a primary care issue. So I think we do a lot of education up front as to what is really a CF exacerbation and why they need to call. As far as being far away, I would say that, for the most part, it hasn't been an issue. As long as the patient's been seen regularly and things are going well, we may be okay to treat over the phone. But the more concerning thing is if they've been treated multiple times and we haven't seen them. Now, we do have in our Holmes County, Amish country, we right now are developing a primary care type of clinic where there's a physician who has a really deep interest in our Amish community, and she's going to be working with us on, and this is kind of a pilot right now, but working with seeing patients because it's such an issue with transportation. I would say most of our patients are really within maybe the 40-minute radius. Once you get out there and you have patients who have difficulties with and it's very expensive. I think one car ride to the CF Center is over $100. It could be even more than that. So if you're an Amish patient, it can add to the expense of everything else that you need to do. So trying to pilot that program so we have that direct communication with them. My adult patients, a lot of them use us as primary care. So I don't have that as much of an issue. I think it's a little more on the ped side that you see that working with a pediatrician. Any other? Okay on that. So just to kind of wrap up some of our ongoing QI, ways we've been continuing to do this is we've applied for quality grants through the CF Foundation, and we've done that. They usually, well, they've done it for the last 4 years. I'm not sure if they're going to do it again, but we've submitted a project plan and ended up getting some funding for our QI, which helps with some of our time that is allotted to this type of work. We serve as coaches for collaboratives from the foundation, so certainly that helps. It kind of keeps you up to date on what's going on, so you get to hear new ideas that are out there and try to implement them yourself. Right now we're active in a leadership collaborative out of the foundation, so again, another area that we're kind of staying really well connected to different things that are going on. We've tried to use, and I've just showed you a snapshot today of QI that we do. We try to use it for our nutrition outcomes. We've done it with chronic meds, and we've also looked to see, not just in general, but in our pulmonary department and in our hospital, how to improve processes, how to improve care that we give. It's improved our team meetings. We're a little more efficient in our communication, which helps with staff satisfaction and our culture. We've used different people like summer students to help with this too, to help collect data. That we have a summer student program where some med students usually come in and work for a few months and they pick a project. So that's been very helpful. And we of course couldn't do it without patient and family involvement. So I'm going to have you go a little forward, just a few more slides here. Oh, and just wanted to show you too, this is what the idea behind QI. So this is the typical Plan, Do, Study, Act. And as you move up, so we talked a little bit about improving the telephone tree, and then developing phone triage for sick calls, and then patient-family education of exacerbations, and then standardized exacerbations. So all these little pieces over time make a difference. So our patient-family council was, typically before we started doing QI, we really used surveys and letters and those types of things to communicate with families. But as we moved forward, it became evident that this was important, and the foundation really had a lot invested in having patients and families involved. It was developed in 2005, and it continues to meet monthly on the last Tuesday of the month in the evening. We have social work, nurse coordinators, and center directors involved. This is the purpose: to serve as an advocate for patients and families, to offer ideas and suggestions regarding policy and practice, to serve as educational role regarding patient-family perception of care and services, to review recommendations and concerns as identified by patients, parents, staff, physicians, or administration, and to assist in planning new services as requested by staff. So this is, they have been a really, just like your family council has been a really great asset and has helped with our spring education day. Also sat on different QI projects. We've had them available by conference call or by phone. So just, being really upfront, showing them our data and having them on our committees to help us improve care. They've helped us look at homegoing instructions. They've helped us revise patient surveys and looking at new education tools. They actually have taken over our quarterly newsletter, and they've even asked patients, we usually write the articles, but we've even had patients write articles for us. And they, again, help with the development of the yearly spring education day. And I actually passed, I don't know if we passed them around yet, but the newsletter, okay. We have a mentoring program also, which has really been developed in conjunction with our hospital. Patients go through HIPAA training, and they learn how to tell their story and how to mentor other patients. What can they divulge? What is okay to give over and to help people during difficult times? And it also helps with fundraising purposes too. And you had mentioned advocacy, another great, another piece that you can use to tell your story. Okay, go ahead. Our Spring Education Day, it's a Saturday program. Usually the family council is the one who decides what topics to be discussed. That's the time we share our registry data also. And we then tape it for distribution for our patients and families that cannot be there. And considering the new infection control guidelines we're actually considering a webinar next year to see if we could have real-time things. We also have education nights. They're typically done in fall. And usually these are just kind of topic-specific things like nutrition or insurance, how to raise funds for great strides, infection control. These are a few ideas that we've had, but certainly these can be expanded, and we're going to continue doing them too. I think I'm done. So, any other additional
We're a
questions?
tiny bit over, but I just have two quick
Yeah.
questions. Is Akron Children's Hospital nonprofit, I'm assuming, or is
Yes,
it for-profit?
it's a nonprofit.
And
Mhm.
so are they pretty tolerant of all this work?
They've been very supportive.
Yeah.
That has not been an issue for us, although we've been very, we've made sure that we've communicated that to administration. Every time we've done any type of work, we've made sure that we've communicated. And I really feel that they value the CF Center a lot. And most of the time, I think they view it as additional training, additional ways to improve care, and hopefully that it will disseminate throughout the institution. Yes, go ahead.
The second question
Yes.
is, you must have a process queen or king in there somewhere. I mean, this is unusual focus
Yes,
on
we do.
process. And
Yeah.
I
Yes.
work in very large companies,
Yeah.
Six Sigma, all that stuff. Was there a personality behind this? Is there one or two people who just like that's their passion? Or
So he's asking
why?
about, yeah.
Why'd you guys get into
Yeah.
it?
Well, I think, asking about it, we do have a champion. We've had a champion physician who really took on the pulmonary exacerbation, Dr. Kranek, and he's actually recently going to be doing some more bigger and better things at Cleveland Clinic. But certainly took this as took this project and ran with it. He was a big champion of it and continues to be so. We also have been, with some of our funding through research, our grants through research, and with the quality improvement, we've been able to fund the registry coordinator, not totally, but the registry coordinator data collection. She kind of does a grants, writing, mixture of things. So you have used some funds to also pull in, and we're very lucky to have her because she is a whiz at this type of data collection and has been able to really, she hasn't always been there. Before, our research nurse would try to make it as simple as possible to collect that data and to Excel charts and those things. She's taken it to the next level. So, yes.
Could you talk about your clinic visits? I'm sure it's very typical as in most clinics. You see everybody on the team. Can you talk a little bit about the chest physiotherapy piece? What happens during that portion of the visit?
Well, we have follow-up visits, and then we have annual visits. And our follow-up visits typically are more problem-focused, but it doesn't mean team members can't be a part, other allied health can't be a part of that. So we're always looking to make sure, especially social work and nutrition, are at some point during the year in the room with the patient. But as far as we have a respiratory therapist who really does, and our physical therapists actually share that role. So for the most part, it's at the annual visit that there's a very in-depth look at their airway clearance techniques, how they're cleaning things, what settings they're using on their vest. And that's usually when it's addressed more than, I'd like to see it addressed at every visit, but I don't think it's happening more than actually asking them, are you doing your airway clearance, and just making sure they're adherent with it. So it's a little more of a yearly type in-depth look at what they're doing right now. And there have been some centers that have done great work with that, looking at it more often, and they've had really good outcomes. Yes, somebody was raising their hand back there.
We have the Family and Patient Council info shares and how to tell your story. One thing I've been kind of keen on doing is also who to tell that story to, besides the obvious, and how to reach out to community groups or employers to go to their staff meetings and things like that. Is that something that
it's along,
shared?
Yeah, it's along those lines. I've actually never been at any of the mentoring program, but I think a lot of it is done to help protect patients and what they share, especially in, and I think it also, they do touch on some social media also during these, and how much you share even online and in various groups and chat rooms, those things. But it is, I think, done to not only help protect the person and how much you divulge to people, but also how can you use your story to inspire others to do things. So it's kind of a little of both of those pieces there.